I would like to thank Elise and Dr. Koitgen for inviting me to give this talk today. I'm going to speak to more than an upset stomach, managing GI symptoms. Neuroendocrine neoplasms are rare, and they occur in various organs, most commonly the pancreas and the intestine. They can be well-differentiated tumors or invasive cancers, and they present with diverse GI symptoms. Tumors that produce a hormone, patients can present with diarrhea, malabsorption, or in the case of gastronoma, where there's excessive acid secretion, peptic ulcer disease, and reflux. On the other hand, non-functional tumors often grow and present with intestinal obstruction, with symptoms of abdominal pain or bloating. They can ulcerate and cause GI bleeding, or they can block the bile duct and cause jaundice or pancreatitis. There are also surgery-related complications of neuroendocrine tumors, mainly diarrhea and malabsorption. Since diarrhea is one of the main consequences of neuroendocrine tumors, I thought I'd speak today about the causes of diarrhea. So in terms of tumors that produce hormones, these hormones either increase intestinal fluid secretion, they can impair digestion in the lumen of the intestine, or they can increase small intestinal motility that can result in diarrhea and malabsorption. On the other hand, in those who have pancreatic resections, these patients have decreased pancreatic enzymes, altered digestion, and rapid transit of nutrients. When there's small bowel resection, patients have loss of surface area for nutrient and fluid absorption. The symptoms of malabsorption and diarrhea include, for malabsorption, gas, bloating, diarrhea, weight loss, and greasy stools that either stick to the toilet bowl or look like oil droplets in the toilet water. With significant fluid secretion in the intestine, these individuals can present with dehydration and electrolyte abnormalities. And then there's vitamin and mineral deficiencies, which can present as anemia, neurologic symptoms, night blindness, rash, or a change in taste. And this occurs when patients have significant malabsorption. I thought it important to review the physiology of the intestine to show you what the intestine is faced with on a daily basis. Every day, about 8 liters of fluid enter the digestive tract. Only 2 of those liters are from oral intake. The rest is from saliva, gastric secretions, biliary secretions, pancreatic enzymes and secretions, and intestinal fluid. And the small intestine must absorb 80% of that, 7 or so of those liters, whereas the large intestine has to absorb the rest, which is 1.4 liters, and otherwise individuals will have diarrhea if this normal physiology doesn't occur. It's also important to review the sites of nutrient absorption. The intestine is fairly smart. It is long, 600 centimeters in length, and overall, most nutrients can be absorbed throughout the small bowel, but there are exceptions. In particular, in the distal ileum, vitamin B12 and bile salts can only be absorbed in this distal position, and this will become important when we talk about small bowel resections. I put a box here to highlight the end of the small bowel, which we'll be talking about next. So first, let me talk about the medical treatment of tumor-related diarrhea. This is, I'm sure, covered in another lecture, but to control just the symptoms of the tumor alone, there's the long-acting somatostatin analogs, which decrease the effect of the hormones being secreted, and those are octreotide or lanreotide. And then there are these newer targeted therapies to actually decrease tumor growth, the mTOR inhibitor, tyrosine kinase inhibitor, and the peptide receptor radionuclide therapy, which is used when people fail these long-acting somatostatin analogs for treatment. I'm next going to turn to pancreas surgery because, again, these are common surgeries done for neuroendocrine tumors. The first is the example of a tumor that would be confined to the distal pancreas. As you can see in the image here, under yellow, it says part removed. So individuals who have a tumor that grows only in the end of the pancreas, the surgeon can take out just the end of the pancreas and leave the head of the pancreas that connects to the bile duct and empties into the duodenum intact. However, in those who have a tumor that grows in the head of the pancreas, which would be on the left, that blue area of the pancreas, those individuals, because of the blood flow, have to have the entire head of the pancreas and the duodenum removed. And the tail of the pancreas has to be repositioned into the end part of the small bowel, and the bile then drains at a separate area into the small bowel. And you can see that on the cartoon, you lose that pylorus oftentimes when individuals have Whipple surgery, which is important for gastric emptying to control gastric emptying. So now let's get on to the consequences of a pancreas resection. So here's the first case. It's a distal pancreatectomy. So in these individuals, they will have decreased enzymes for digestion because half of the pancreas is gone. That results in fat malabsorption and diarrhea. It's also interesting that the islet cells are predominantly positioned in the end of the pancreas, so diabetes is more common with the distal pancreatectomy. And the treatment in these individuals are supplemental pancreatic enzymes to improve digestion and thereby improve absorption and lessen diarrhea. On the other hand, in the so-called Whipple surgery, where the head of the pancreas is removed, now you can see the anatomy that where the tail of the pancreas empties into the intestine and where the bile duct from the liver empties into the intestine and where the food from the stomach empties into the intestine, they're at remote areas instead of being clustered right next to each other. And this decreases, first, again, the enzymes for digestion, and there's what's called impaired mixing of food with digestive enzymes, such that it's not as efficient, and that impacts on absorption and malabsorption. Then there's rapid emptying of the stomach, the so-called dumping syndrome, which can very quickly cause food to move through the small bowel to the point where it can't be absorbed. And lastly, this all can result and frequently results in weight loss in patients who have Whipple surgeries. Treatment is to change your eating to frequent small meals, avoid simple sugars, add the supplemental pancreatic enzymes, and take a daily vitamin and mineral supplement. If weight loss becomes very rapid early on after this surgery, sometimes we need to give parenteral nutrition so that we can provide nutrition support until the digestive tract is working better. I'm next going to talk about small bowel neuroendocrine tumors. This is the most common tumor of the small bowel, and it often involves the distal ileum with or without lymph nodes and the mesentery, and oftentimes there's multiple tumors. The clinical presentation is abdominal pain, small bowel obstruction, or GI bleeding, and resection is usually surgically. We cannot endoscopically remove these tumors because they're growing from under the lining, and the small bowel has a very thin wall, so it's not usually safe to remove these endoscopically unless they're very small. The consequences of ileoresection include diarrhea, malabsorption, and vitamin and mineral deficiencies. And I want to show you two cartoons here. The blue is what's ghosted out or removed in the resection. So there's two scenarios long term. There's the limited ileoresection where less than 100 centimeters is resected. And here, bile salt absorption and B12 absorption is usually pretty preserved. So in these patients, a regular diet and a multiple vitamin is standard in terms of dietary therapy. And then either we give a bile salt binder called cholestyramine or an antimotility agent to slow down movement through the small intestine. And we monitor patients for their bone density, fat-soluble vitamin status, vitamin B12, and for urine oxalate, because individuals can, in this setting, develop oxalate stones. The second scenario is the ileoresection with greater than 100 centimeters resected. Here, the bile salts and the B12 can no longer be absorbed in the small bowel, and bile salts are particularly needed for fat and fat-soluble vitamin absorption. So here you want to change your diet to a low-fat and low-oxalate diet, so that would be a high complex carbohydrate diet. Supplement with vitamin B12 and a multivitamin and mineral. Take extra calcium in the diet and an antimotility agent, again, to slow movement through the intestine to improve absorption. And then cholestyramine or a bile salt binder can be used, but one must be careful because that may bind up more of your bile salts and worsen your fat malabsorption. And the monitoring is for bone density fat-soluble vitamins and urine oxalate. So in summary, GI symptoms can be a sign of neuroendocrine tumor or a consequence of surgery. Diarrhea is the most common GI symptom. Tumor-targeted therapy includes the somatostatin analogs and the new therapies, which can significantly lessen diarrhea and malabsorption. And then there's the post-resection management, which includes for ileoresection, a change in your diet, bile salt binders, and antimotility agents. For pancreatic resection, there's diet and pancreatic enzyme supplementation, and of course, monitoring for vitamin and mineral deficiencies that need to be supplemented. But the important part here is you need lifelong monitoring to avoid malnutrition and these vitamin and mineral deficiencies. So it's important to be monitored lifelong for health because we'd rather prevent problems than try to deal with them when they occur. So on that note, I thank you for your attention, and I look forward to answering any questions you have.